فلاجي ريبورت فورم
or to improve adherence to these two important tools. The system is said to, we call it Adhere system or AMCH tool, and we deployed this system in public health facility in Hamara region. I think start. So one of the particular component of, as part of this, the clinical decision support system, e-partograph is part of this tool. So this e-partograph is characterized by automatic drawing of graphs, avoiding retrospective fillings of those data which are entered to the partograph, and it provides a measurement view for healthcare providers. So it also provides a list of suggested intervention that can assist the healthcare provider to improve the service delivery or the quality of service. These are the interface that are just when we open the system, these are the interface. And these are the partograph which is ready for just completion during the at point of care. And these are the complete partograph, and it's one element of the partograph. It shows that when the provider didn't adhere to the timely filling of this partograph, it will show that as the time passed. So that it could be one indicator for the other important tool is the WHSCC. So we deployed these two systems to improve the adherence. So the overall objective is to examine the effect of these interventions on adherence to labor and delivery care in public health facilities. As to the study setting, we conducted we deployed the system in 5 intervention health facilities, while 4 are considered as control health facility. Particularly, we deployed in health center and hospitals. The design is a quasi-experimental design. Particularly, we used a pre-post design with non-equivalent control group. And the implementation design which we used is a hybrid type of design. That means hybrid effectiveness implementation design. Particularly, the type 3 is we prefer to use. But our focus is, our main goal is just to see the implementation outcomes, while at the same time we try to see the effectiveness of these two tools in terms of improving of the adherence. So the intervention packages are just adhere-based implementation of the partograph, as well as the WHS is one important intervention. The sample size we followed, we reviewed baseline and the inline assessment. Our just data collection techniques, record review. We reviewed the system, the records which is already imputed in the system, as well as on the card. On the controls, we used the regular paper-based recording system. So the data collection techniques are the review of labor and delivery charts. We developed a survey checklist to do this. We trained midwiferys to capture this data, and we used EpiCollect 5 software in order to access the data from the control healthcare facility, while we deployed at baseline at both the control and intervention facility. The analysis is difference in difference analysis. To declare whether there is a significant difference, we use difference in difference analysis. These are the overall study process. We do have 3 phases. The first phase is the preparation phase. The second phase is the intervention, and the third phase is the evaluation phase. Adherence tools, we do have just 2 outcomes: adherence to partograph and adherence to the WHO SCC checklist. These are the measurements that we have used to measure adherence to partograph. There are parameters that are embedded in the partograph. So by using those scores, we generate 0 to 9, while we generate adherence to WHC by looking at 4 subtypes which is completed at admission, before childbirth, after childbirth, and just on discharge. So these are the findings. Just we found that there is a significant increase due to implementation of this e-partograph. That means 4.25 point increase has been one evidenced due to the implementation of the e-partograph. There are studies which have been conducted so far by using this e-partograph. So the other findings, just the previous findings, are also showing that the greater adherence has been recorded on the e-partograph compared to those paper-based partograph users. So clinical decision support system has been shown that improving of the adherence to the quality of care. These are the other crossover study which has been conducted, whether the e-partograph has produced significant difference. So our finding is also in line with other findings. The other important outcome variable is WHO adherence to WHO SCC. We do have the on-admission checklist, adherence to on-admission checklist, adherence to the before birth checklist, after birth, and the discharge checklist. So there is significant improvement across the three of the checklists, particularly the admission before and the after birth checklists, while the last, the discharge checklist didn't show significant improvement due to our just adhere system or adhere intervention. So the earlier studies are also showing improvement because of implementation of this, particularly the safe childbirth checklist, when they have been guided by just by different interventions, the improvement has been increased. So these are it shows that the alignment with our findings. The other findings has been just conducted a cluster randomized controlled study conducted, also showing that because of coaching-based implementation of the safeguard checklists, there is significant improvement in terms of adherence. Well, coming to the conclusion and the recommendation, so this adhere intervention significantly improved adherence to partograph as well as WHO safe childbirth checklists, except the discharge checklist. The system, so we recommend that based on this finding, we recommend for just broader implementation, but this broader implementation or scale up should consider the different mitigation strategies, particularly the implementation challenge should be considered. We published the implementation challenges as in paper 1, particularly using the logic model and the CIFR framework. So the use of implementation logic model also an important element to just guide the intervention of these e-health interventions. For researcher, just we employed the just record review, so direct observation could be the best thing to show whether there is significant adherence, and also clear we can ascertain that the provider, whether they are adhering to the recommended interventions. When we compare the record may be completed without a practical implementation of those things, but observation can solve that issue. Strong design like cluster randomized control trial may be recommended. The feasibility and acceptability of scale-up of this adhere system also another important issue that could be researched for future just before maybe scale-up. So I would like to say thank you, my supervisors. This work is part of my PhD. And I will just acknowledge also the adhere research system or research team. Particularly, we do have clinicians, public health, and the technology experts to develop the system. And the other, the funders, the AFI is one funder, FNOT project, and Bahar Dar University are acknowledged for funding of this project implementation. So the study participants also acknowledge. Thank you for the organizers of this event. Thank you.
Thank you, Dr. Dabra, for completing the presentation before time. You said about 3 minutes, so thank you for that. Is Dr. around? I think he's not here. So I think we should proceed to the discussion, or shall we present the remaining two papers which we have scheduled after tea break? Nazan present our discussion anyways. Do you agree? Okay, thank you. So I think the presenters are around. Undaya? Is Undaya around? Okay. Dasalo? I think we need their consent too if they are ready to practice for 40. So, Dasalo, are you ready? Sorry for the inconvenience እንግዲህ አንዳንድ ቴክኖሎጂ በዚህ ቻሌንጅ አለ። The good news is that this is fixed now. So just about 15 minutes you can continue.
Thank you. My name is Isalo Sando. I work in Amara Public Institute. The title of the presentation is Assessment of Suicidal Acts and Community Perception towards Suicide in Public Hospitals of Amara region, and it is a mixed cross-sectional study. My presentation will these the following outlines, and I will go through the policies one by one to my time. And to begin with, by defining suicide, when we say suicide, it is derived from a Latin word which is called suicide. And suicide means self-murder or self-killing. And as to American Psychiatric Association, suicide is defined as a completed intentional action of ending one's own life. It is an intentional action of killing oneself. That means a completed, that ends with death. When you say suicide attempt, it is a non-fatal. Unlike suicide, it is a non-fatal, intentional, self-injury. One may try to hurt his or herself by using different means. And if this outcome is not death, we can say this is a suicide attempt. Suicide is the 10th leading cause of death worldwide, and globally, from 10 to 20 million people experience suicide attempt. And annually, there are about 800,000 deaths worldwide. That means 1 in every 40 seconds, 1 day from suicide. Among these 800,000 days, annual days, 75% of which are in low and middle income countries. And in the last 30 years, in low and middle income countries, there is about a 365% rise of suicide days. That means there is a 4.65 times or fold increase of suicide days. Okay. Global, it is very difficult to find the true figure of suicide in the general population, because the true figure of suicide is affected by different factors. Among these is there is no one and straightforward standardized method of data collection, because by its nature, suicide is associated with socio-cultural condition of the environment.
As a result, different population or different countries have different socio-cultural conditions. And so that there is no one and straightforward, or there is no one and rule of thumb method of collecting data and to have a true figure of suicide. The other is suicide has a legal issue. In some countries like Kenya, those who attempt suicide can be jailed or arrested for about 2 years and more. And there are also other factors that affect the true figure of suicide. Like suicide is also associated with crime and insurance. Those who commit suicide, if they are performing this within the first year of signing an insurance, can be ignored, or they may be denied. And because of this, people may not tell the truth about suicide, about committing suicide. Because of this and other many factors, the true figure of suicide in a population or in a country or at a global level is impossible to find the true value, but there are estimates. If you say, like in Ethiopia, the lifetime prevalence of suicide may range from 0.6 to 40%. And death from suicide is about 8 days in 100,000 days. From 100,000 days that occur in a condition or in a certain population, 8 of them are because of Shall I continue? There are many different factors that or means so that suicide can be conducted, like that of self-gunfire or hanging and poisoning. Among these, self-poisoning is one of the most common cause of suicide and suicide attempt in the Amhara region. We conduct this study because there is high prevalence of suicidal behavior in Ethiopia. There is high mortality and morbidity due to suicide is one of the targets of the WHO program, and is also one of the indicators of the Ethiopian mental health program. So that it is better to have the estimate of the status of suicide in the region. The other is because, like I said, suicide is associated with different cultural conditions of the environment. Little is known about the feelings, how suicidals feel, or how the community think about suicidals. So we want to add some qualitative feelings about suicidality and suicidals. And the objective of our assessment is to have the status or the outcomes, to estimate the outcomes of suicidal acts and the perception of the community towards suicidals and suicidality in public hospitals of Amhara. The study was conducted at emergency departments of public hospitals in Amhara region from September to October 2024. And an institutional retrospective cross-sectional design was used for the quantitative, and a phenomenological research design was employed for the qualitative data. And our data source is a registry data in hospitals, a registry and chart data of suicide cases who visited emergency department and selected hospitals of Amhara region from July 1, 2023 to June 30, 2024, and a multi-stage sampling method was used, and finally a total of 5 public hospitals were selected or sampled for our study. The qualitative data includes key informant interviews, focus group discussions, and in-depth interviews, and these participants were selected because of the intention to have a rich information source or to maximize our information. And tools like the assessment tools and interview guides were used for the quantitative and the qualitative data to assure the quality of the data. A field team of data collectors and supervisors were recruited, trained for half a day, and oriented, and at the same time, we used mobile-based application, ODK, to keep consistency of the data among data collectors and between study sites. The quantitative data was collected by ODK, then exported into Excel, cleaned, and then to spaces where descriptive studies was performed. Whereas the qualitative data was transcribed verbatim, then translated into English, and then back to translated, and then thematic analysis was used to triangulate the data with the quantitative data. Ethical consideration, here we have obtained ethical approvals from our Publication Institute. And to come with the finding of our data, our study, a total of 5 hospitals were sampled, and a total of 565 suicidal acts were reviewed. And here, as the graph indicates, the green shaded ones are those number of suicidal acts that are recovered after visiting the hospitals, and the red shaded ones are percentage of days, and yellow shaded ones are percentage of suicidal acts that are whose outcome is not known. And in Addis Ababa, 51 suicidal acts were recorded, 222 in Kalagayot, 147 in Dasi, and totally 46 days were recorded. That means 8.14% of case fatality rate, and 458 cases or 81% were recovered, and 61 or 10.8% were unknown. The outcome of this much number of cases were unknown. That means there is a big incomplete data that needs to be our qualitative participants also. They told us that the number of suicidal acts were increasing from time to time, and they told us that the number of cases will be higher than what is currently reported in hospitals. And our finding, that means 8.14 suicidal days, is comparable or similar with the finding of a study by the Salo et al. In Black Lion Hospital, and it is much less than the rate of the mean fatality rate of 2 studies in Amara region, that is 26%. And this may be because our data has large number of unknown outcomes. That means these unknown outcomes may be days because they are not recorded, and their outcome is not known. That means they might have been days. And the possible cause for this is incomplete record and data tracking that may hide the true figure of suicide and may contribute for poor intervention or delay in intervention. The other social demography we viewed is sex, that is, the number of cases were higher in females than males, and it shows a ratio of 1.7 to 1, that means about 2/3 of the cases were females. From our key informant interviews, we found that participants said that males are better in managing problems than females, so that males are less vulnerable as compared to females. Other similar studies in Ethiopia and Turkey and And India also shows that there are higher rates of suicide case in females than males. And this may be because difference in gender might have caused a difference in exposure and vulnerability to challenge between genders. As we see here, the number of cases in youths are very large as compared to older ones, and more number of suicide cases were found in teenagers, followed by those in 20s and 30s. Relatively, there is high percentage of cases in youngs and early adulthood. If you take the age from 11 to 30, there is about 78% of the case. And the age from 11 to 40 took about 90% of the whole case were found in these age categories, that is from 11 to 40. That means all these are the youth and early adult individuals. The average age of these all cases were 26, and this is in line with a study by Adeno in Gondar, who found that 25% of 25 who found that the average age of these suicide cases were 25. That is very similar with the finding of our study. And this may be because at the age of adolescence and youth, there is age-driven changes, hormonal and behavioral changes. These changes are characterized by different behaviors like stress sensitivity, emotional instability, and adjustment disorders. This will, if they are triggered by social and environmental factors, they may lead to an increased risk of suicidal behavior. Nearly 2% of the cases were found to be repeated suicide attempts, and this as compared to the 30% repeated suicide attempt in Jumma. The variation may be due to the population difference, that the study in Jumma was from those attending in hospitals or mental illness patients who are normally at high risk of repeated suicide attempt. And this indicates that strict integrated medical care and management together with follow-up. On the other hand, the majority of the suicide cases were due to ingestion of chemical substance. Other similar studies have got their findings. The major cause or means of suicide was ingestion of chemical substance. This may be because these ingestible chemical substances are easily available everywhere. And the agents, the most commonly used agents are organophosphates and metal phosphates. These are the agrochemicals, which make up 83% of all the cases. The reason for, or the agents used by suiciders. These agrochemicals were the most commonly used means of suicide for other, they were reported as a means of suicide for the majority of the cases in other studies by Asri et al., Gaite and Belainer, and other authors have found that these agrochemicals were the most commonly used means of suicide. This may be because we are following an agriculture-led economy. That means to increase production, there are many chemical products used by agriculture, by owners of agriculture. That means there are easily availability of pesticides.
Sorry, can you go to the main point? You used 2 extra minutes.
Okay. On the majority of the cases we found in our study only received medical care alone. That is also supported by suicide survivors. and that shows that a need for an integrated medical and mental treatment. Regarding readiness of facilities, a total of 1,357 number of healthcare professionals were found eligible for training, and only 9 were trained for chemical poisoning, that means 0.66%, and 1.47% of healthcare providers were trained for suicide case management. That means very little number of healthcare professionals were trained for management of suicide and chemical poisoning. If you see this number in terms of facility, only the SE and Falagate hospitals were those who have trained healthcare professionals for management of chemical poisoning and suicide. And among these two is the SE, which is relatively better, but in general, there is very low training rate. And studies showed that there are standards that individual participants, healthcare providers working in health facilities should obtain at least the basic trainings for management of hazardous substance. But in our findings, there is only little number of trainings. And there is also only few facilities who have provided health education, and in our region there is no poison information control center, which are very important tools for management of suicide cases. Our qualitative finding also showed that there is inadequate awareness of mental health issues. Our community, most of our community associates the cause of suicide with Satan or jinn. Suiciders do that because Satan or jinn rides them and to do so. And they usually stigmatize these suiciders. And other similar studies also found that stigma is a very common practice towards suicide attempters. And if we see the cultural and religious prevention methods, we found that sticking on religious principles is an opportunity if mental health issues are not overlooked. Usually, these religious principles push individuals who have these thoughts towards churches, and the thoughts and principles in churches are all protective. They discourage suicide. So this may be suggested as a potential place for prevention program. To come to the conclusion, there is high fatality rate with critical data tracking gaps, and women and youths are more vulnerable to suicide, and agrochemicals are the most commonly used means of agents, and there is insufficient training of healthcare providers on chemical poisoning and suicide case management, and also there is low mental health awareness in the community, and there is stigma towards suicidals. And we do have these recommendations. One is regulations on toxic chemical substance should be enforced to limit access of this chemical substance to high-risk groups like youths and females. The other important recommendation is health facilities should, the regional health bureau and mental health programs should ensure that health facilities train their staff on chemical poisoning and suicide case management. And the need of poison information control center is very critical because it helps us to run a toll-free support line to provide training and timely diagnosis and care. And finally, I would like to thank these bodies. Thank you, everybody.
Okay, thank you, Mr. Saleh, for the very informative presentation. Now it's time for discussion. We will have discussion on all the three presentations, probably for 30 or less than 30 minutes, depending on the number of issues to be raised. So I will call up all the presentations here to receive comments and questions. Come here. So you can raise questions and comments. I will give numbers. So number one is 1. Okay, so you will introduce your name and then you will continue questions. Actually, we will begin after giving the chance for other participants too. So 2, anyone? It's 3, 4. So number 1, we can start. It's about.
I have 2 questions actually. It's okay, I think I'm loud enough. 2 questions. One is just to clarify the last presentation about the suicide incidents. You mentioned, for example, 63% of women are suicide cases, right? And you meant overall, so deaths plus attempted suicides, so recovered, plus unknown outcome cases, right? Out of all of these, 63% are women. Would it be correct to say that the majority of men actually manage to implement that suicide, to go to the end, to kill themselves? So while women, in majority, they attempt suicides. They are the majority of those cases, 63%. Per your statistics, do men actually constitute the bigger percentage of those who actually kill themselves? So not just all suicide cases, but just those fatalities. And the second question would be, is there any statistics, is there any study that you've done where the study actually researches the causes behind those suicides? Because you mentioned stressors in general are the main cause of the suicides. But is there something that says, for example, women and girls in this percent commit suicide because of gender-based violence, and more specifically, conflict-related sexual violence? So it would be interesting to know the answers to these 2 questions. Thank you so much.
Thank you.
Thank you, Dr. Nasrallah. Basically, the issue of suicide is very timely because there are reports indicating that the rate of suicide is increasing from time to time, which is linked mainly to the existing social situations and the prevalence of conflicts. Yes, the topic is very relevant. I have a question regarding your methods. You claim that you applied mixed research approach, and here you have to specify which strategies were used on the mixed research approach. There are different strategies, for example, sequential and concurrent. You have to make a justification. Again, you mentioned that you employed phenomenological inquiry. Is it appropriate to use phenomenological inquiry while applying mixed research approach? and try to clarify when do we use phenomenological inquiry. Even there are two types of phenomenological inquiry. One, transcendental phenomenology, and the second type is hermeneutic phenomenology. Which phenomenological approach was used for your study, and what was your justification? Also, you claim to apply the research approach. I am reversing the question of study participants. Where is the data generated from quantitatively? You use the engaged interview, you use key informant interview. But where is the question of study participants related to your research objectives? Hence, I feel that the qualitative part is overlooked. Another question, you mentioned hormonal and genetic factors as a cause of suicide. I think, is it proposition supported by scientific justifications? Are there evidences supporting this view? Thank you very much.
Thank you, Dr. Samson. Number 3.
Okay, thank you for your nice presentation, all the presenters. I have some question or suggestion concerning about the research title, barrier practice and advanced utilization suite factors. Presented by Mr. Magistu. It's a very nice presentation and it is untouched study teams. First, I wonder your input. The next one is you have to use a mixed design. What is the reason to use this mixed design? Why you have been at least with a quantitative approach? Even if you have to use a mixed design, in the result and discussions session, there is no a description or explanation what the quantitative findings states that, and what the quantitative findings is that, whether correlated or uncorrelated. Because we have to use different reasons to use this mixed design. In my recommendation, this is not aligned with the objective of the study. The next one, when we can say ambulance utilization, I didn't see on your slide the operational definition concerning about ambulance service utilization. So it needs clear operationalization. Is that an individual use an ambulance once a year or perhaps 1 time, 3 times, 4 times? It needs further more clarification. This is my personal suggestion. The next one, your sample size also too small in my understanding, because we have access to use much more sample size. I don't know the reason, even if it is some justification adjustments. And the other one is I didn't see the logistic regression theory in your presentation, because it is important to the audience to see that logistic regression and your finding, whether it is true or false, whether it is statistically valid or not valid. So it means even logistic regression slide presentation. The last one, in your conclusion and recommendation section, in my understanding, your recommendation seems like to general recommendation. Beyond your finding, it is better to recommend depend upon your finding and other tasks. I appreciate. I wonder your effort. Thank you so much.
Thank you. Number 4, thank you, Dr. Musa.
Okay, thank you all presenters for coming with your findings, just to stimulate for the audience and for speakers. Saying this, I will start with the first presenter, Magistu. I think your title is new approach, and my first question is, how do you choose this title? Was it really relevant to be studied? Because we know most of the factors that have lead to down ambulance utilization rates for the target population right now in the region. What new findings you bring and recommend to be implemented with the presence of especially the current situation? Because we know that most of the people are just using ambulance for other purposes. That is the common reason in our region for low utilization rate. So what is new beyond that? And most of, I fully share the concern raised by the former person who raised the reason to use mixed data design. That was also my issue. And most of your results were with higher odds ratio. What would be the reason? The odds ratio was very high, but I didn't see the exact figure. And most of your results were contradicting with study findings from JIARC. What would be the reason? Really, is the JIARC is highly different from JIARC? What would be the reason? I didn't see the possible justification for that. And recommendation, how do you see the feasibility of your recommendation, especially just allocating ambulance in each category? Is it feasible? And what's the national guideline says about it? The allocation distribution of ambulance. Is it by at least by facility or by each category, or what's your best to say just to recommend to have available ambulance on that? And I didn't see even recommendation just to use ambulance for their primary purpose. That is our current issue. Your design, just my comment, I think your design, it says pre and post quasi-experiment, and you also said that as you have 5 intervention and 4 control areas. So how do you see these two issues? Pre and post design versus just having other also approaches like intervention for control. Why not before and after within the intervention area even? Was experiment before and after the vice mentioned, bullet points design industrialization data. Maybe the limitation you recommend most of your limitations just for further research. For example, observing the practice. Evaluating interoperability in the market. Do you think this can be just topics for us further research? I think most of these points we have the limitations of the team to conduct. The salon, who will interviewed the salon, especially for quantitative, who will interviewed for your data source? Just I could share with points raised by Dr. Santor. And I didn't get what were the possible factors that lead people to attempt suicide from their study. Why? That was very important. It is because of just making your qualitative study shallow. I didn't see even quantitative results there. So, what were, from your experience, what were the key important factors that lead people to attempt suicide based on your study? Recommendation, just most of the victims were younger and females, younger and females. But I didn't see recommendation targeting those populations. Recommendation, because your key findings are just the victims. So just your recommendation should focus on those target populations. So I didn't see a recommendation targeting those the most affected population components. Thank you.
Thank thank you all for raising the most important questions. I think the presenters shall respond to these questions and suggestions, and we will continue to the second round of questions and answers if any. So I will start from this tool for convenience of mic sharing.
Okay, thank you for the chance to respond and accept the comments and suggestions. First, I would like to say to ask great apologies for the inconvenience or technical error I made during uploading the document in the API system. Uploading the document which is prepared for workshop, validation workshop at the Government University. That was the problem, and I wanted to ask apologize for the audience and the organizer. When I come to the questions raised by esteemed audience, the first one is the definition or operationalization of ambulance. Ambulance service utilization in this study was operationalized when the patient came to the health facility to seek some medical or surgical care. They came as using or on foot using commercial vehicles like taxis, buses, and ambulance. So, what was the mode of arrival to this healthcare deliveries is one of the questions delivered to each respondent. So, the mode of arrival to the healthcare delivery, the healthcare setting or facility is considered as an outcome or ambulance utilization. The other one is why you used a mixed approach. We all know that we hypothesize that the prevalence or the utilization of ambulance to be low. It is obvious, and it should be scientifically supported rather in addition to saying this problem. So, first, we conducted a quantitative study at selected public hospitals, and we got relatively low prevalence or low utilization of services. So, we wanted to explore the reasons or the challenges or the barriers why individuals couldn't use ambulances to get into the health facility. So, in order to explore the reason or the barriers and the community-led perceived solutions, we used qualitative design to dig out the perspectives of individuals, the perspectives of responsible bodies like the Journalism Department, Red Cross coordinators, and chief executive directors of the hospitals and the centers. So, the other is your sample size is low. It is enough to see some statistical association because it is the method of calculation using to get the minimum sample size to SAR-MD to see any statistical association between hypothesized predicted variance or significant variance. But it can be more than this. But as I said earlier, this study was funded, or the financial source of this study was Marcus University, and the university not allowed for samples greater than this figure. And the other one is, I think this is a logistic regression or table for logistic regression, and I apologize for the technical error, and I have regression table I have shared for the audience and for readers, and the recommendation, your recommendation is general. You are right, and I'm accepting your suggestion. Commenting. And the other one is what new findings you bring. The first one is the current utilization of ambulance in the study area is unknown, especially in the area of conflict. We know that air ambulance service were interrupted due to this conflict, but it should be scientifically documented. And we try to explore the bias and the community perceptions. So this will add some scientific background or some scientific evidence to the current knowledge. The other one is the odds ratio is high, it's not critic. I think the sample size we bring this high odds ratio, and the other one is the same observation, the number of observations which is observed in each cell may be the reason, and the other one is the feasibility of your recommendation. I recommended the regional bureau to deploy other additional ambulance to each of the facilities rather than Warada level or Warada level or district level. Because most of the ambulance, as the qualitative study or the qualitative finding shows that most of the ambulance stations are reserved at Warada level, and the communities cannot access these ambulances because their station is far from the community or the communities who live in the rural area. So I recommend the responsible bodies to station or to design the station of ambulance for each health facilities rather than Warada or district level. The other comments and scientists provided we had to do the document. I will now accept it with great honor. Thank you.
Thank you, Minister.
Thank you. And to begin with the first question, is 63% of females the whole side activities days and annual days, or only the days was the person? And this 63% of females were of the case where females is containing or it is some of all side activities days and unknown days in our finding. When we see the days part only, nearly number of males and females were equal in number. But the larger proportion of the case in the whole side activities is females. This is the whole body of the whole case. And the reason for this may be because females, usually in our cultural context, females are not, they do not have the same freedom as males, and they are usually under the control of their families, usually. And we know that nobody let his daughter after school anyway, because they are easily affected by any violence. So, because of the violence and because of the high control, females may need to have a hidden relationship And this, if they lose their relationship, if there's a conflict between the relationship, this may risk them for suicide. And these are some of the reasons we found in our review. And because our data is retrospective, we are not we do not have the chance to collect the real factors for suicide, rather to collect what is documented in the records and charts. And from here, what we found is about 62 cases were found to have some factor-related data in their chart, and we aim these factors into two as personal and relationship factors. And the majority of the factors were relationship factors. That means loss of relationship in a family, or loss of friendship, and some violence between relationships. These were some of the factors as a relationship factor. And in our personal factors, some of the factors for suicide attempt in our study was violence in the family, and economic factors, and an inability to meet parental expectations. That means their failure in their education or in their works. This leads them to be hopeless, and that finally make risks for suicide. And the other question is my presentation or my assessment was cross-sectional, mixed cross-sectional study, and we used concurrent quantitative and qualitative. We collected data at the same time because we used the qualitative for triangulation, and we do not have a quantitative data approach or quantitative data approach. Rather, we want to describe what the quantitative data says, and at the same time, what do people perceive about suicide and suiciders qualitatively. And for that purpose, we use the concurrent approach, and to find the lived experience of suicide attempts. This phenomenological approach was preferred, and we follow that. And where are the interviews? Who are interviewed? I think one of my the question is, who are individuals who are interviewed, and it is interviews for suicide attempts. Index participants for suicide attempts who have served in that facility for 6 months. And key informants were healthcare providers who are managing and working at that specific health facility. And focus group participants were community members in the nearby of the hospital. Like I said, why do people commit suicide? There are a number of factors, but because we collect retrospective data, we only have the chance to review the record data, and like I said, we classify this in personal and relationship factors, where the most common underlying factors of suicide. And in the recommendation part, I think we have mentioned specific targets to work on controlling or limiting accessibility of chemical substance to youth and females in our recommendation. The first recommendation is particular focus in youth and females. Did I address all?
I just received just a couple of questions. Just maybe start with the design. The question related to the design. Pre-post is one of just the simplest form of precise experimental design, which didn't show. For example, if some intervention produced once you have taken the baseline, you have no orders to justify whether your intervention is bringing a change because of your intervention or because of the newly introduced intervention. So for that matter, for this reason, we consider the experimental design with a control group in order to just at least to overcome such kind of problem. Because our intervention, we took the baseline prospectively 1 year, recovery. Then we deployed the system in the forward for 1 year. So between this time, there may be new interventions, new strategies that have been introduced at regional level or at national level in order to overcome this issue. We prefer to have a control. So these are my response regarding the first question. The other, as you said, of course, most of the things we recommended are based on our limitations. Still, if anyone who comes with a better resource, time, the like, these are the limitations that could be seen as a research, as a future research. But we do have just a recommendation for the policy as well as for the program, just considering the effect and the considering the scale up. But if you use the scale up, you have to give attention for particular systematic design that you have to support. Because we put all the learning as part of one system, so that having just time keyboard during the design or keyboard design the intervention is very important issue for advocating for policy makers. So these are my suggestions.
Thank you, President, for the introduction. I think we can conclude the session here for the sake of time. So, it's good for the presentation. And once again for your contribution. Thank you again, the presenters, and thank you all for your attention.
Jangan ada cara kata terkini, ada cara kata. Ada negara besar ni. Saya betul. Kalau dia negara present cara ko, thank you. Ini masalah. Ini masalah. Mungkin masalah.